Hi, I'm Lynn Jacobs, Assistant Nursing Professor at Fresno State University, which is located in Central California. I want to talk to you about a study that we did on asthma screening. First, the learning objectives that should be in the program. I'm going to talk about the difference between fine and coarse particulate matter. I'm going to describe the asthma screening questionnaire that we used and talk about the role of spirometry in diagnosing asthma. The purpose of our study was to evaluate the utility of our mobile health unit that you saw in the first picture, staffed by student nurses who we have trained to perform spirometry training on patients. We are using those participants who live in rural Central California, who we believe have experienced high levels of exposure to coarse particulate matter. So it's always important, to define, how did we say this was rural? How do we define rural in the study? And it's a little bit difficult because, Fresno is a large county, but, it has one city in it, and that's Fresno. So we have a lot of outlying rural ag areas. So we took communities that were at least 25, closer to 40 miles from the Fresno city limits. These communities were accessed by rural county roads, no two-lane highways, and they were served by no more than one rural clinic. The second purpose of our study was to assess the reliability of the asthma screening questionnaire that was previously developed. And we wanted to do this to kind of screen out those people that probably didn't need spirometry. Here's some background of our study. Like I mentioned, we're in Fresno County. It is the largest county in Central California. And in the nation, we are the largest ag producing county. So very, very important to the economy of California. But it also has some of the worst air in California. And it's been, Fresno has been called the asthma capital of California. And this worst air comes from pollution from both fine and coarse particulate matter, which I will go on to define. Here's some more demographics of the Central Valley, which you can see in the dark blue here is Fresno County. We have the highest rates of childhood asthma, ED visits in the state. Overall, 14% of Californians have been diagnosed with asthma. We use that as a benchmark. And we have an additional 10% of Californians who have asthma, but it's gone undiagnosed. We also, when we're talking about air quality, need to think about COPD as well, because often patients with an underlying history of asthma have also developed COPD in their lifetime, and that is 4.3% of Californians. I mentioned small particle, large particle size. Here you see that they've given you, for reference, fine beach sand and a human hair. So when we're talking about large particle size, we're talking about PM 10 or less. And that's also termed respirable dust. So we can breathe that and it can get down fairly deep. When we're looking at the PM 2.5, we're primarily looking at car emissions, smog, gases, those kind of things. So for our study, we were really interested more in the coarse particulate matter, which would be dust. Dust that our rural ag workers are breathing, not only them, but their family members that live out in these areas. And studies have shown, particularly the MICASA study that was done by UC Davis in one of our rural communities in Central California, that there is a very high rate of asthma. People think that, just because we're talking about rural areas, that, we don't have the smog. So, and we don't have the manufacturing. So our air quality, they think is probably good. But besides respirable dust, we are also nowadays looking particularly at wildfire smoke. Right now in California, Oregon, and Idaho, we have massive wildfires that are dropping ash, smoke all over. It's really bad. And then, as this image shows, we also have airborne chemicals from agriculture. So when we're talking about diagnosing previously undiagnosed asthma, the gold standard for doing that is spirometry. I wrote a grant and our nursing school purchased 2 spirometers. We went through training on how to use them. And then we trained the students. And these were students who were taking simultaneously critical care or complex care and community health. So in my complex care class, we gave them the modules, we did the hands-on training with the students, and then for their community health, they went out on the mobile clinic and put that to use. We wanted the students to measure 2 things. Well, actually just one, but it takes 2 measurements to get that. And that's the forced expiratory volume at 1 second divided by the forced expiratory volume at 6 seconds. I read multiple studies which talk about this particular spirometry measurement as being one of the most reliable to do in the office. It's easier for patients to do, particularly if they're undiagnosed and they have a chronic respiratory condition. And when we look at whether or not this patient meets the threshold for referral, we're looking at those patients whose screening test results were less than 80% of predicted normal. And we predict normal based on age, height, weight, that kind of thing. This is a graph of what you might see on a spirometry. I made all kinds of laminated graphs showing the student what a bad test would look like. And if this is what their test looked like, this is what they needed to do to fix it. And then of course they had a standard as what would be good. I mentioned the asthma screening questionnaire. And again, we tried to pilot this. It's a very, very easy to administer tool. You can see here, there are 6 questions. This was developed out of the University of South Florida College of Medicine, and I did receive permission to use it and to translate it into Spanish. And we did use a Spanish interpreter for that. So you can see some of the questions, do you have a worsening of the following symptoms when you lie down, cough, chest tightness, wheeze. They ask if a problem talking on the phone, do you cough a lot, those kind of things. So here are our results. We wound up screening 61 adults in 3 different rural communities. Most were Spanish speaking. I used hardly any of the English literature that we had. We had 8 clients, or 13%, with either low FEV1, meaning those participants could not hold their breath for 6 seconds. So we had to take their FEV1. Or they had a low FEV1 divided by FEV6. And the 13% that we came up with was prevalent with, or met our benchmark of 13.8% in the state. We looked at the ability of the ASQ then as a reliable screening tool. This was a little bit different. We had 29 false positives, which was almost 50%, and 3 false negatives. Our results indicated that this was not a reliable instrument for the population that we screened. And possible reasons that we came up for those findings were that we had a less heterogeneous population than was used in the initial Florida study. So our participants were primarily all Hispanic. They were primarily all over, 55 years old. They were primarily all ag workers. They lived in a very high, an area that had a lot of coarse particulate matter. So we didn't have a good cross section of the state, but that's not what we were concerned with. Another possible reason is that our participants were largely rural. Probably a high majority of them were illiterate, and they spoke mainly Spanish. We're not really sure how well they wrote Spanish, though, but we know they spoke it. Also, there are different dialects that I just found out from my future daughter-in-law that are being spoken down there. We might not have, hit all of those that we should have. The main problem, though, that I see is that we self-administered, or the ASQ was self-administered, rather than having one of our Spanish-speaking students read it to the participant and clarify any questions at the time. I think that would have been helpful. So here's our conclusions. Using the asthma prevalence rate in California as a benchmark, we accurately screened residents of rural ag communities for chronic respiratory conditions. If you properly train the student nurses and you have NPs such as myself overseeing them and evaluating the results, we can provide this service to people who don't otherwise have access. We have recommendations and future plans. One of those is to initiate pre and post bronchodilator testing for patients whose history is consistent with airway disease. Those patients would have to be examined by the mobile health unit NP to make sure that the bronchodilator, which causes tachycardia, that the patient doesn't have any underlying cardiac problems. And again, I mentioned utilizing Spanish-speaking students to read over that ASQ and to clarify any questions. So overall, we felt that our study was a success. We are going to continue to do it. We had to take a year off because of COVID. Certainly, we don't want people, breathing deeply into our machines who might be infected with COVID. This is my email, ljacobs@mail.fresnostate.edu. If you have any questions or would like to start one of these programs in your own community, I'd be happy to talk to you about it. And here is the list of references.